Welcome to today's unfolding case study designed to sharpen your clinical judgment for the Next Gen NCLEX RN. Today, we'll explore this patient scenario to analyze cues, plan safe interventions, and evaluate outcomes using evidence-based practice. So let's challenge your clinical reasoning and strengthen your decision making. Let's begin. Here's the case scenario of a 29-year-old female who presented to an outpatient mental health clinic for a routine follow-up. It says in the history and physical, the patient has bipolar II disorder diagnosed 2 years ago. She was hospitalized for a manic episode 18 months ago, stable on lithium 900 milligrams daily for 1 year. She's married with 2 children, ages 2 and 4, part-time graphic designer. Recent stressors included increased work demands, parenting challenges. She denies substance use or medication non-compliance. For the physical exam, she appears restless, animated. For her neuro, she is alert, oriented with rapid speech. For psychiatric assessment, she has elevated mood, denies suicidal ideation or psychosis, and there are no focal neurological deficits. And here are the vital signs. On day 1 at 9 a.m., blood pressure from 130/82, heart rate 88, respiration 16 breaths per minute, and temperature of 98.2. So here's a task for you to complete. You're going to highlight those findings in the progress notes that are most critical for identifying a possible hypomanic episode in bipolar II disorder. So here's the progress notes. It says, patient reports feeling better than ever with tons of energy, denies mania, appears animated, talkative, slightly restless, reports sleeping 4 to 5 hours each night, impulsive spending, $500 on art supplies, and racing thoughts. Denies recent substance use or medication non-compliance. Reports increased work demands and parenting challenges. Reviewed recent routine labs such as TSH 2.8 milliunits per liter, creatinine 0.9 milligrams per deciliter, complete blood count normal from 3 months prior. Communicated patient symptoms and clinical findings to the psychiatrist, prompting a lithium level order. So I want you to carefully read those lines so to make sure that you are not committing any errors. Now let's start here. One of those lines is this one. We have feeling better than ever. This one stands out because it reflects an unusually elevated or euphoric mood, which is a key DSM-5 symptom of hypomania. Even though the patient feels great, it's too great. This kind of better than ever feeling is not just as good as today. Now, it's a red flag in the context of bipolar II. And here, whenever there is a mood that seems disproportionately high, then think about hypomania. The next line here is tons of energy. This is another core symptom of bipolar II disorder, hypomania. It's not just having a good day energy. This one is sustained, it's excessive, and often not in line with their normal functioning. So you got to be always be alert when someone describes this much energy without a reason, like caffeine or rest. The next line is animated, talkative. So this is more than just usual, especially rapidly or with a lot of enthusiasm. This can reflect pressured speech, which is listed under DSM-5 criteria. So here you're looking for objective behavior to back up the subjective reports. Another is sleeping 4 to 5 hours each night. This one is a huge key, especially in hypomania, because patients often sleep much less and still feel full of energy. And that's not typical. So if someone's running on little sleep and feels energized, this one strongly supports a hypomanic picture. And this one, impulsive spending, $500 on art supplies. Of course, when they do this, out of whim, this is considered risky behavior, which is part of the DSM-5 criteria for hypomania. And these kinds of impulsive actions also signal impaired judgment, even if they seem productive at that time. This one is also part of it. Racing thoughts often can go hand in hand with the pressured speech and also reflects the cognitive speed up that's common in hypomania. So you're going to think of this as the mind going too fast, which is another critical symptom. And so the rest of the options here or words are not to be highlighted, such as slightly restless. Why? This is not highlighted. Well, you might think about this as part of that. And this one is too vague. It's non-specific. So this could be due to anxiety, could be medication side effects, or even stress, but not necessarily hypomania. And it does not meet the DSM-5 criteria directly. So we are going to set this one aside. If you highlighted denies recent substance use or non-compliance, well, this is just a piece of information that will help rule out other causes, but this will not help us tell of what the patient is experiencing. And this one is not a symptom. This is a way up to eliminate those confounding factors. And the rest of the phrases here, like reviewing recent labs, this is a nursing action, which is unrelated to their hypomania. Or if you highlighted reports increased work demands and parenting challenges, these are the life stressors, and also explain why someone might feel tired or overwhelmed. But these don't help you diagnose hypomania. And so you gotta consider that context really matters here. And if you selected communicated patient symptoms, this is also a nursing intervention. It's not something the patient is experiencing, so eliminate that. Now let's go into the next asked item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
We have a bow tie. It says here, the nurse assessed the patient's elevated mood and energy, noting her denial of mania despite concerning behaviors such as reduced sleep, impulsive spending, racing thoughts. Suspecting hypomania, the nurse communicates findings to the psychiatrist, prompting a lithium level order. So looking into the healthcare providers here, it said that there was an order for a lithium level stat at 9 a.m. and then at 10 a.m. there's an order to continue lithium 900 milligrams daily as needed. And so here we have the lithium level of 1.0 milliequivalents per liter. And on day 1 at 10 o'clock, we have the nurse's progress note stating lithium level 1.0 reports occasional nausea and hand tremor, denies severe side effects, educated on hypomania signs and lithium side effect management by taking with food, reduced caffeine, and psychiatrist was consulted for medication adjustment. So here's our bow tie question. You have the following options for the side effect. So here are the choices. One is nausea, we have hand tremor, bradycardia, hypothyroidism, and seizures. So in this scenario, you're choosing the right side effect and intervention that will best address the most disruptive side effect. And let's go ahead here. Let's answer the side effects. So what do you think would best fit? Well, the answer here is hand tremor, because lithium commonly causes the hand tremors, especially fine motor tremors, even at therapeutic levels. And in this case, the client is a graphic designer, so that tremor can directly interfere with their ability to do their job. And since this is affecting their daily functioning and quality of life, it becomes the top priority here. So in this, you need to think about how the side effect impacts the person's real life, not just what's happening physiologically. And in this case, losing fine motor control has a bigger impact than the others. Now, let's pick into the next side effect, which is incorrect. Nausea. Why not? Even though this is a known side effect of lithium, it tends to be mild and temporary. And the key difference here is that nausea is not stopping the client from working or doing day-to-day activities, unlike the tremor. So for here, the mild symptoms that do not interfere with functioning are not the priority when something more disruptive is present, such as the hand tremor. Now, let's look into bradycardia. Why not? Well, look into the labs, the vital signs. The patient's heart rate is 88. So it's totally within the normal range. And bradycardia is not a typical side effect of lithium when the levels are therapeutic. So here, you need to always want to match the symptom to the drug's expected profile. And if it's not supported by the data or the labs, then it's probably not related. Now let's look into hypothyroidism, which is also incorrect. We know that lithium can cause hypothyroidism, but it's usually a long-term issue. And in this case, the client's TSH is 2.8, which is within the normal. So there's no current problem regarding their thyroid function. So here, do not get distracted by the possible risks if they're not showing up late in or showing up in the lab results or the assessment findings. So you got to be careful. And lastly, we have seizures. The seizures can happen when the lithium levels are becoming more toxic, typically above 1.5 milliequivalents per liter. So you got to keep this in mind. And since the patient's lithium level is only 1.0, which is within the therapeutic range, seizures are not going to be an issue here. So you need to save those severe complications like seizures for situations where there's actual evidence of toxicity. So that's how you're going to eliminate each of these distractors. Now let's move into the 2 teaching points. And the options are: take lithium with food, increase fluid intake, monitor heart rate, report weight gain, reduce caffeine intake, and monitor thyroid function. One of the answers here is take lithium with food, because this is going to help reduce the side effects like nausea, tremors by slowing down how fast the drug is absorbed in the gut. And this can also help the client tolerate the medication better, and they can stay consistent with the doses. So here, teaching should make the medication easier to live with and also encourage long-term adherence. The other intervention or teaching point, I should say, is reduce caffeine intake, because caffeine can stimulate the nervous system. It can make the tremors worse. And since the patient is already dealing with tremors, cutting back on the coffee or energy drinks can make a very noticeable difference. So here it's very important for you to teach the client to avoid things that will worsen the specific side effect, especially once they can control, like the intake of caffeine. Now let's look into the other options which are incorrect. If you selected increase fluid intake, we know that this is important in preventing lithium toxicity because lithium is cleared by the kidneys. But that's not the issue here. The problem is tremor, not toxicity, and the client labs are actually normal. Take a look into the lithium. It's within the normal range. So here you only include those teaching point or interventions that relate directly to the side effect that we are targeting. And again, that's the hand tremor. This is somewhat kind of a good advice, but within the wrong time. Now let's look into the other teaching point, monitor heart rate. Why? We know that this is not going to help with tremor, and tremor is a neurologic effect. It's not a cardiac one. Plus, the vital signs that we have gathered are normal. So here you need to match the teaching to the actual system affected. So do not just monitor things unless there's a reason. Now let's move on to the next one. Report weight gain. Well, this one relates to thyroid function, which can be affected by lithium over time. But in this case, the TSH is normal. And we know that tremors and weight gain are unrelated here. So you got to keep your teaching focused. Do not bring any other side effects if they're not currently an issue. So that's the key here. And we also have the last one, monitor thyroid function. So this is more related for long-term monitoring strategy, but it's not directly connected to managing the patient's hand tremor. And remember that the question is about an immediate problem. It's not something that might develop later. So that's a huge difference there. And here, long-term precautions are important, but not when you're addressing the hand tremor at the moment. So you got to focus on that one. Don't get distracted. Now let's move on into the two boxes for a client statement indicating understanding, and the options are: I'll get my thyroid checked monthly. I'll report if I gain weight. I'll stop drinking coffee. I'll drink more water. I'll check my pulse daily. I'll take my lithium with meals. Now, what are these two answers here? So here's the first answer. I'll take my lithium with meals. So this tells you that the patient remembers your teaching about taking the lithium with food to reduce nausea and to reduce tremors. And this one also shows they're taking steps to manage the side effects. So here you're actually looking for those client statements that reflect accurate understanding and good follow through on what was being taught. Now the other statement should be this: I'll stop drinking coffee, because this one shows the client made the connection between caffeine and tremor and also plans to adjust their lifestyle accordingly. So that's a huge win. So do not forget to look for signs that the client knows why they're making changes, not just that they're following orders. So you gotta pay attention to those subtle cues. So the rest of the options here are incorrect. If you selected I'll check my pulse daily, well, there's no need for us to do that based on the current concern. And tremor is not related to the heart rate, and there's no evidence of bradycardia. So here, if you did not teach it and it doesn't make sense for the symptoms, then do not consider it correct. If you selected I'll drink more water, again, this is good for preventing toxicity, but the issue right now is the tremor, not lithium toxicity. So you got to stick to self-management that matches the active problem. If you selected I will report if I gain weight, well, this is something that's tied to possible thyroid effects from lithium. But right now, the thyroid labs are normal, and the client should be focused on the tremor. So here, do not chase unrelated symptoms. You got to focus on what's happening at the moment. And lastly, if you selected an incorrect option, I'll get my thyroid checked monthly. Well, that's not part of the treatment plan. We know that thyroid checks are part of routine monitoring, but it's not something the client needs to worry about monthly unless they're instructed to do so. So here you have to avoid recommending unnecessary or overly frequent monitoring unless it's clinically indicated or ordered by the medical provider. So Feel free to pause this video and reflect your answers and the rationales that I just discussed. All right, let's go into the next test item, number 3.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
It says here at 11 a.m., the psychiatrist orders lamotrigine to augment treatment. The patient reports irritability, distractibility, and difficulty concentrating, prompting further intervention. So pay attention to the healthcare providers here. We already tackled the first 2 orders. And at 11 o'clock, it said, start lamotrigine 25 milligrams daily, PO, titrate as directed. So the task for you is, for each client need, select appropriate nursing interventions. Each need may have multiple interventions, and each category must have at least 1 selected. So here's the matrix. Focus on to the client needs. 1 is managing hypomanic symptoms, ensuring medication adherence, and promoting long-term mood stability. So at this point, you can pause the video and decide the correct answers for this test item. So if you've done that, let's go ahead and select those answers. Now, for the first client need, what do you think would be the best answers here? 1 would be to teach relaxation techniques. And this is something that you're going to keep because strategies such as deep breathing exercises or mindfulness can help calm the nervous system. And these approaches can reduce irritability and impulsive behaviors, which are going to be common in hypomania. So my tip for you here is to choose nursing actions that directly target that elevated mood or energy level. The next potential nursing intervention is encourage structured daily routine, because this is going to help create consistency, especially around sleep and activity. And remember that people in a hypomanic state tend to lose structure. So this is going to keep things from spiraling. So I want you to go for those strategies that prevent symptoms from getting worse, and that's why you're going to select this. Another option is to coordinate therapy referral. So this one stays on your list because therapy like cognitive behavioral therapy or psychoeducation can help the patient understand their condition and spotting early warning signs, and also can manage their stressors. And this is especially important since the client is showing denial. And if the issue is chronic, or if it's complex, or if it's tied to insight, you got to get the care team involved. Now, the last option in this category is incorrect. Monitor vital signs. Well, you can skip this because her vital signs are stable and it doesn't really tell you anything specific about their mood. And in this case, monitoring their blood pressure doesn't do much to manage their hypomania. And my tip for you here is that routine checks are low priority unless they relate to the mental health concern. Now let's jump into the next category, ensuring medication adherence. One of the answers is teach medication schedule. This is going to be very vital because knowing when and how to take their medications like lithium or lamotrigine is very critical because timing affects blood levels. And when they're going to miss the dose, this can lead to mood swings. So my tip for you here is about adherence, which is key to their safety or stability, and it should be part of the teaching. Another intervention that you should pick is use pill organizer. This is very practical and easy for clients to do even with their busy lives. And having an organizer can reduce the chance of missed or double dosing and also support their long-term medication compliance. So you gotta choose those tools that make their life easier, especially those managing multiple medications. Another answer is reinforce lab monitoring importance. So you need to hang on to this because laboratory for the lithium is very critical to their safety. And you have to keep in mind that lithium has a very narrow therapeutic range, which requires regular checks to prevent toxicity. So you got to highlight this type of intervention to maintain medication safety as well. Now, this one right here, encourage family support. This may sound good to be checked off, but this doesn't directly improve adherence like giving tools or explaining lab checks. We know that family support is more of a general support strategy. It's not an RN specific action here. So you have to prioritize interventions that come from the nurse, not others. All right. Let's look into the last one, promoting long-term mood stability. And the answers here include teach stress management. This should stay on your list because stress is one of the biggest triggers for mood episodes. And when you're teaching the patient how to manage it, can prevent both mania and depression from returning. So better address the factors that push the client into a relapse. That's very huge. Another intervention is to encourage sleep hygiene because regular restful sleep can help regulate their mood, and poor sleep can actually trigger those hypomania or mania. So establishing sleep routines is a huge deal in bipolar care. And don't forget that you have to look for those interventions that tackle common relapse triggers. Now, looking into the last two here, one of the answers is to reinforce follow-up appointments. This is very critical because mood disorders like bipolar require ongoing management, and regular checkups can help provide also better care, and the healthcare provider can catch the changes early. So there should be some kind of continuity of care, which is a key in managing chronic conditions like bipolar disorder. And lastly, promote balanced diet. This sounds good, but it's not really specific enough to bipolar disorder. Unlike sleep or stress management, diet is not directly tied to mood stability in this scenario. So you have to focus on targeted interventions that directly help control the client's symptoms or prevent relapse. Let's move further into the next item, number 4.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
The nurse reviews the progress notes for day 1. So looking at the documentation entered at 9 in the morning, we're not going to go read that one more time because we've done that already. The same thing with documentation entered at 10 o'clock and at 11. It says here, reports irritability, distractibility, and difficulty concentrating at work, denies suicidal ideation, psychiatrist ordered lamotrigine, educated on lamotrigine side effects and administration, follow-up scheduled in 1 week. So here we have a matrix. It says, indicate the conditions associated with each clinical manifestation. So you have different conditions: bipolar II hypomania, generalized anxiety disorder, we have ADHD, and hyperthyroidism. So you're going to select which condition matches to the individual manifestation. So here, I want you to think like a nurse when analyzing cues to understand which conditions might match to the patient's symptoms. And again, the goal is to match the finding to what's actually seen in the DSM-5 criteria for the common clinical presentations. So let's start with the first one right here, irritability. What do you think about this? Well, this is associated with bipolar II hypomania because that's part of the Diagnostic and Statistical Manual of Mental Disorders criteria for hypomania. And not everyone with hypomania feels euphoric. Some feel on edge. They are also snappy or unusually reactive. And that still qualifies an elevated or irritable mood. So yes, hypomania fits here. Now, think about GAD, or the generalized anxiety disorder. Do you think that this is going to fit as well to irritability? Yes, it does. Well, with a GAD, it's like constant tension under the surface. Here, people worry so much that it wears them down, affecting their emotional reserves, and they can become irritable, especially when the worry interferes with daily life. And according to the DSM-5, it even lists irritability as one of the diagnostic symptoms of a generalized anxiety disorder. Now let's move on into the next condition. It's also going to match with hyperthyroidism because this is a physical condition and it affects their mood as well. So when the thyroid is overactive, the body is in overdrive. Their heart rate's gonna start racing. They're gonna be jittery. They get so anxious and easily irritated. And the nervous system is overstimulated, so irritability is a common symptom here. But not ADHD. Why? We know that people with ADHD can get frustrated and might seem irritable. Well, that's usually secondary to the other problems, like being unable to focus or being misunderstood. But DSM-5 does not list irritability as a core symptom of ADHD, so we do not consider it as key diagnostic feature here. So we're going to keep it unchecked. Now let's pay attention to the next manifestation, distractibility. This is about struggling to stay focused, not just daydreaming, but actually having trouble holding attention when it matters. So let's take a look if it matches bipolar II hypomania. Yes, it does. This one makes sense because when someone is hypomanic, their mind is racing. There are too many thoughts coming out at once, so they're going to jump from one idea to another and get distracted easily. And pay attention to the DSM-5. It lists distractibility as one of the hypomanic symptoms. Now, what about the other conditions? It's also associated with ADHD. And remember that this is one of the hallmark features of ADHD. This is inattention, and that's part of the criteria. So patients with ADHD will struggle to finish tasks or follow through because their focus constantly shifts. And the same thing is going to happen with people with hyperthyroidism, although it's a medical condition. But with hyperthyroidism, this is going to speed up everything, including their thought process. Patients with this condition can feel restless, they get so jittery and mentally scattered. So it's going to make it hard to concentrate on anything for long. So it can cause distractibility too. However, this one is not associated to generalized anxiety disorder, even though they may seem distracted, but they're really not. They are actually stuck in a loop of worry. So their attention is not jumping around, it's just fixated on fear. And that is why distractibility doesn't match the clinical picture here. Now let's move on to the next one. Difficulty concentrating. So this is one a very important aspect, because this one shows up in a lot of different conditions, and the reason for the concentration problem is what helps us sort them out. So let's look if it matches with bipolar II hypomania. Yes, this is present. This is something that when the patient will have racing of thoughts, it's almost impossible for them to focus. And because the brain is moving way too fast to settle on one idea, so even if the patient is energetic and talkative, they cannot actually focus on anything deeply. And this is also associated with GAD, because in this condition, the patient is not racing mentally. They're stuck in their worries, okay? And it's hard to concentrate when your brain is locked on what ifs. So this is also a DSM-5 criterion for anxiety. Now, do you think that this is also seen in ADHD? Yes, it is, because the concentration issues are foundational in ADHD, and people with this condition struggle with sustained attention, organization, and follow through, and that makes this one an obvious fit. And the same thing applies to hyperthyroidism. So we're going to put a check mark here, because with hyperthyroidism, they can feel constantly on the overactive metabolism. They will have that mental restlessness. They will have trouble focusing and irritability. Even though it's not psychiatric in nature, it still causes impaired focus. So nothing here is ruled out. Now, what about racing thoughts? This is all about subjective mental speed, feeling like their brain won't shut off. And so this is going to be seen in bipolar II hypomania. This is a classic DSM-5 symptom for this condition. And people with hypomania describe their thoughts as moving so fast that they cannot finish the idea before another one takes over. And again, this is part of the flight of ideas seen in manic and hypomanic episodes. Also associated with a GAD, because the thoughts are not fast in a joyful way. They're actually repetitive, anxious thoughts. And patients will often say, I can't stop thinking about what might happen, even though it's not racing like in mania, but there's constant mental activity. So it fits here as well. However, this is not going to be associated with ADHD, because in that condition, there is more of inattention than rapid thinking. Patients may be impulsive, but they don't describe their minds as racing. They just get distracted easily. And racing thoughts are not part of the diagnostic picture as well. So we are not checking off that box. And the same applies for hyperthyroidism. Although they may feel jittery or anxious, but they don't describe cognitive racing here. And the problem is more physiological. They are shaky. There are going to be palpitation, but it's not a subjective experience of fast thoughts. So we're not going to checking that box as well. Now let's move into the reduced sleep, 4 to 5 hours each night. What do you think about this? Well, this means they probably have insomnia or a true decrease in sleep need. So those are very different. Okay. Now let's look into the bipolar II hypomania. Do you think that this is associated with that one? Well, it is, because this is a key diagnostic and statistical manual mental disorder. This is part of the criteria. And it's not just that they don't sleep, it's that they don't feel tired despite it. And people with hypomania often sleep 3 to 5 hours and still they feel full of energy. And that's very different from someone with insomnia who can wake up feeling so exhausted. And another condition that is associated to this one is hyperthyroidism, because this is going to rev up the metabolism, which can interfere with restful sleep. And the person may wake up frequently or sleep fewer hours due to restlessness or nervous energy. But for GAD and ADHD, there's no association here. Well, let's talk about the GAD, why it's not associated to this manifestation. Well, even if GAD causes insomnia, but the patients typically want to sleep, but they can't. They will lie awake worrying and feel tired during the day. So this is not a reduced need for sleep. It's more of like a struggle to get it. And for ADHD, sleep is not part of the core ADHD criteria. And some individuals with ADHD may have sleep problems, but it's not diagnostic and they don't usually have a reduced need for sleep. And that's why we're not going to associate with this manifestation. Lastly, we have impulsive spending. This is true to bipolar hypomania, right? This is part of the Diagnostic Statistical Manual of Mental Disorders, DSM-5. And one of the diagnostic criteria is excessive involvement in activities that have a high potential for painful consequences, like reckless spending or gambling. And here, there's that impulsivity. This is mood driven, meaning it happens during periods of elevated or irritable mood. However, this one is not associated with GAD, because people with the GAD are the opposite. They're very cautious and risk averse. And they would not go on a spending spree because they are too focused on avoiding bad outcomes. And the same thing happens with ADHD, because impulsivity is part of ADHD, but it usually shows up as a blurting out, interrupting, or jumping from one task to another. But it's not commonly tied to financial risk, or especially in the absence of elevated mood. The same thing with hyperthyroidism, although patients may seem restless or driven, but there is no evidence that it affects financial decision making, or if it can lead to impulsivity like hypomania does. So I want you to reflect your answers here and compare it to the rationals. Let's move on into the next item, number 5. It says the nurse reviews the healthcare provider orders day 1 at 11 a.m., noting lamotrigine addition. The nurse anticipates further medication adjustments. We have the same entry for the nurse's progress notes. Let's jump into your task here. It says complete the statement by selecting the appropriate options from the word choices below. So here's the statement. The nurse anticipates the healthcare provider will monitor blank and adjust blank due to blank. So here you're looking at a case where the patient is still showing signs of hypomania despite being on lithium, which is known for having a narrow therapeutic window. So your role is to think through what actions the provider might take and anticipate them like a clinical detective. So here are the options. For motor options, we have thyroid function, liver function, lithium levels, blood glucose. For adjust options, we have valproate dose, carbamazepine dose, lithium dose, lamotrigine dose. And lastly, for the reasons, we have the options: risk of hypoglycemia, interaction with antidepressants, narrow therapeutic range, and risk of hepatotoxicity. I hope that you have decided which options you're going to fill these blanks on. All right, for the first blank, the correct answer here is lithium levels. This is top priority because lithium has a very narrow therapeutic range, typically around 0.6 to 1.2 milliequivalents per liter. And that means there's not a lot of room between a dose that works and a dose that can become toxic. And so in this case, the client's lithium level is 1.0, which is technically within the therapeutic range, but they're still showing signs of hypomania. So we cannot assume the dose is effective. And the provider might decide to adjust the dose or frequency, but that decision depends on accurate, up-to-date lab values. So the clue for you in answering this question is always keep a close eye on medications, especially that it requires right dosing. So you want to catch toxicity early and make sure that the medication is actually working. So the rest of the options here are incorrect. If you selected blood glucose, this is one easy pass because neither lithium nor lamotrigine usually mess with the blood sugar. Plus, the client does not have a history of diabetes or symptoms of hyper or hypoglycemia, so there's no indication that glucose levels need monitoring. If you selected thyroid function, it's true that long-term lithium therapy can lead to hypothyroidism, so checking the TSH is appropriate. It's just not in this situation because the current TSH is 2.8, remember? Which is completely within the normal range. And right now, we are dealing with ongoing hypomania. It's not about long-term maintenance. So even though thyroid labs matter for the lithium users in the long run, but they're not the priority at this moment. Now, if you selected liver function, this doesn't really apply here either because lithium is not metabolized by the liver. So this one is excreted by the kidneys. And liver function tests are not helpful in tracking or lithium toxicity safety either. Now, pay attention to the lamotrigine included. This can very rarely cause liver problems, but it's not common. And unless the patient shows symptoms like jaundice or let's say liver tenderness, we don't need to jump to the liver function testing. So we're gonna have to save liver monitoring for medications like valproic acid or carbamazepine, so mostly anticonvulsants, which are known to affect liver. Now, let's look into the second blank here. So that's about adjustment. So the answer here is, of course, lithium dose. This makes perfect sense because the client is still hypomanic, even though their lithium level is 1.0. That suggests the current dose of 900 milligrams might not be cutting it. And since lithium is the main stabilizer here, the provider will likely consider tweaking the dose a little higher, always keeping the risk of toxicity in mind though. Now, the other options such as lamotrigine dose, even though lamotrigine is part of the plan, it was recently added, so it hasn't had enough time to show its full effect. And remember, lamotrigine is titrated slowly to avoid serious side effects like Stevens-Johnson syndrome. So it's not something we jump to adjust right away. So think about that. So the focus right now is on the drug that's already at the therapeutic dose, which is lithium. Now, the other options such as valproate dose or carbamazepine dose, these medications are not even part of the client's regimen, so get rid of these. These are not also prescribed, so we cannot obviously adjust their doses here. Now, let's look into the third blank, which is all about reason, and the options are risk of hypoglycemia, interaction with antidepressants, narrow therapeutic range, and risk of hepatotoxicity. The answer here is narrow therapeutic range. That's quite true. And that is the main reason why both monitoring and dose adjustment of lithium are so important. And you have to remember that there is that very narrow therapeutic range for this drug. So it means even small changes in the dose, or let's say changes in the body's ability to clear, let's say if they get dehydrated or if there are any kidney problems, this can lead to toxicity or ineffectiveness. And that is why we are going to implement regular monitoring and making sure that we are very cautious in adjusting the dose of their medication. So the pearl for you that I can give you right now is that when a drug requires close laboratory checking and precise dosing, that should be your main reason of action. Now, if you selected risk of hepatotoxicity, well, remember that lithium does not mess with the liver. And if this were, let's say, a valproic acid, then yes, but not here. It's not applicable. Now, if you selected risk of hypoglycemia, again, neither lithium nor the lamotrigine can affect the blood sugar, and there's no reason for us to think about this option as well. Lastly, interaction with antidepressants. Well, this might make sense if the client were also taking antidepressants, but there's no evidence that he or if she is taking those medications. There's no report that she takes selective serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors or even tricyclics. So there is no drug interactions to worry about. So here, don't bring in interactions for medications that are not even on the patient's medication regimen. So you got to be careful. Let's move on into our next test item. This is a trend.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
It says here, you review the follow-up flow sheet over 8 weeks, assessing treatment efficacy after lamotrigine initiation and lithium continuation. So feel free to scan this. This is quite lengthy. We have the time point when the patient went to the clinic. We got week 1, week 2, week 3, week 4, week 5, week 6, week 7, up till 8. And you have the documentation here for their vital signs and the mood rating from 0 to 10. 0 being stable. All right. And the documentation about hypomanic episodes in that particular week. So you can pause this video and pay attention to that flow sheet right now. All right. I hope that you have already decided to discriminate all those important cues in the flow sheet. So here, when you're going to evaluate the outcomes, you're basically checking if the patient's treatment is helping. And for hypomania, which is part of their bipolar disorder, you're going to look for those signs that are about the key symptoms, like reduced need for sleep, risky behaviors or impulsivity, or even mood instability. All right. And you'll want to pick patient statements that show improvement in these features. So let's reveal right now the patient statements. One of the options says, I still feel irritable sometimes. I'm eating healthier meals. My hand tremor is completely gone. I'm sleeping 7 to 8 hours per night now. I haven't made any impulsive purchases in weeks, and my blood pressure is lower than before. Again, the task for you to do is to select those 2 patient statements that best indicate the effectiveness of the treatment plan for managing their disorder. So let's answer this one. One of the answers is, I'm sleeping 7 to 8 hours per night now. This is a big green flag for improvement, because before the treatment, the client was only sleeping 4 to 5 hours at night, which is a classic sign of hypomania. People get so energized even with little sleep. And getting back to 7-8 hours tells us that the symptom is resolving. So an improvement in the sleep is also an improvement in hypomania. So you got to always look for those changes in their sleep pattern. Another correct answer is, I haven't made any impulsive purchases in weeks. This is another sign that the treatment is working, because impulsive spending is a risky behavior. It's linked to hypomania, and we know that patients often buy things they don't need or they cannot afford. And if that urge is under control now, then the medication is likely doing its job. So my clue for you is, if there is any pattern that they have reduced risky behaviors, then that means that they have better impulse control. So that's a huge progress in hypomania management. Now, if you selected, my blood pressure is lower than before, sure, the blood pressure lowered slightly from, I believe, 130 over 82 to 124 over 76, but that doesn't tell us anything specific about their mood or bipolar symptoms. It might be from some maybe lifestyle changes or reduction in their stress, or even chance. It's not relevant to the question. And so here, blood pressure changes are not part of hypomania symptom. And you're going to need to look for mood-related changes instead. Now, if you selected, I still feel irritable sometimes, well, this tells us the opposite of improvement. And we know that irritability is actually one of the diagnostic features of hypomania. And so if the client is still irritable, that's a sign that the condition is not fully under control yet. Now, if you selected, I'm eating healthier meals, well, good for that patient's overall health, but eating better doesn't reflect whether the hypomanic symptoms are resolving. And here, diet is not a clinical outcome that we are monitoring for. And so we're going to eliminate that. And if you selected, my hand tremor is completely gone, we know that this can be caused by the medication, especially lithium. And the resolution of tremors tells us more about the side effects, not whether hypomania is improving. And the question is about treatment efficacy for mood symptoms, not side effect management. And that's why we're not going to check that box. So here, do not confuse side effect relief with the core symptom resolution. So you have to focus on the mood, not the motor symptoms. So here in this test item, when you are evaluating the outcomes for mood disorders like bipolar hypomania, you need to zero in on the symptoms listed on a DSM-5. So recall about sleep, the patient's energy, risk-taking, mood elevation, and impulsivity. And if the patient statement reflects improvement in these areas, bingo. That is your answer. So let's recap our test items. And I hope that you're learning from this exercise. For test item number 1, that was a hotspot. So we recognize cues on that item. And remember that we have highlighted those manifestations directly tied to the Diagnostic and Statistical Manual of Mental Disorders 5 of hypomania criteria. So don't forget that. For test item number 2, that was a bow tie. We generated solutions and we prioritized hand tremor as the key lithium side effect. And we chose those interventions directly addressing the tremor as a side effect, and also avoiding unrelated actions like monitoring the heart rate or increasing fluid intake, which are more relevant for toxicity prevention. For test item number 3, that was multiple response grouping. We prioritized hypothesis there. So in that item, you selected those targeted interventions for hypomania, their adherence, and stability. And we selected the nurse-driven bipolar specific intervention over general health measures like balanced diet or less direct options like family support. In test item number 4, that was matrix multiple response. So in that item, we focused on symptoms exclusive to hypomania, such as impulsive spending, to confirm the diagnosis while ruling out those conditions with non-specific or absent symptoms. In test number 5, that was a drop-down rationale generated solutions. Here we prioritized lithium-related actions over unrelated monitoring like blood glucose check or medications not ordered like valproic acid. And in test item number 6, that was a trend. We evaluated outcomes. So in that item, we selected outcomes directly tied to hypomania resolution and nursing interventions, and also excluding those residual symptoms such as irritability and unrelated issues such as headaches. So that's it for today. If you find this review session helpful, do not forget to subscribe to the YouTube channel for more NCLEX prep content. Give this video a thumbs up and share it with your friends preparing for the NCLEX. Thank you for watching. I'll see you again in the next session.